right, so let's get started. Thank you everyone for joining us this evening or this early morning, depending on where you are. So we are very happy to host this QA session and try to answer some of the questions that you might have about the coronavirus outbreak that is happening and affecting everyone globally. I'm Vahe Khachadourian, assistant professor at the Turpanjian School of Public Health at the American University of Armenia, an epidemiologist. Very happy and delighted to have Dr. Haroutune Armenian with us, President Emeritus, and I'm sure that you all know about him, but I would let Dr. Armenian to introduce himself, and then perhaps we can start with the opening remarks, and then we'll move on with the questions.
Oh, so I'm Haroutune Armenian, and I'm professor in residence currently at UCLA, in addition to being President Emeritus and leading the Turpanjian Rural Development Program in Armenia. My background is in epidemiology over the last 50 years or so. And I am also very much engaged in the application of public health methods across many countries. This evening, we have this Q&A session. It's the first time I'm using this Zoom, so it may be, I may make some mistakes, but hopefully it will be smooth. Through the communication department of AUA. The first thing I would like to raise, hopefully this hour or so that we will be together, we'll be able to respond to some of your questions, but I would like to have this session as much as possible not repetitive of the flood of information that you are exposed to day in and day out from the various media. Everything today turns around the coronavirus and the epidemic or the pandemic that we're dealing with. Be that as it may, just to mention a few things, since I'm going to speak about the United States. In general, we're dealing with over 200,000 cases by now in the United States, and some 4,000 plus deaths that have been registered as a coronavirus related death. Now, it is important to consider that the United States is not this homogeneous country. It has 50 plus the states and the various governmental units geographically dispersed around the a vast geographic area. So what is happening in New York may not be the same as it's happening in Puerto Rico or some other constituency. So this is important to consider when we're looking at the data and what's happening in the United States. So Vahe, would you like to say a few words about what's happening in Armenia?
Yeah, absolutely. So yes, so just to echo with what you mentioned is about that, is very different because each state has a different situation and different response, which of course leads to a very different picture across the country. So what I can say about Armenia, and then I would like to start more on the global picture, that saying that this the first coronavirus case, the first one was identified late December, and then it was January 13 when WHO declared a global health emergency, and then it was by February 2nd that we had the first death due to coronavirus registered out of China, and it was in 11th of March that WHO kind of now identified and characterized this condition as a pandemic. So what has been happening in Armenia, as I'm sure most of you know, is that the first case was identified in 1st of March. And as of end of March, there have been a total of 571 confirmed cases of COVID-19. And unfortunately, we have had 3 deaths. So that's basically a kind of snapshot summary of what's going on. I mean, if you look at the timeline, you can see that how rapid this has developed. And for the general population, this kind of might look surprising, but for those who know that infectious diseases, it's not really a linear growth, but it's an exponential growth. So that doesn't really come as a surprise that we are right now dealing with almost 1 million cases. It's actually more than 900,000 confirmed cases of COVID-19. I'm sure if you take into account the undiagnosed cases, that would be way more than that. But that's the current situation globally and in Armenia. So before moving on, one logistical thing that I would ask you to direct me your questions. So you can direct me your questions via the Zoom chat function, and then we'll try to answer them as we go on. All right, so let me move on with the first question, which I actually asked about, so it says, you mentioned about the situation in the US and Armenia. How would you evaluate the actions and measures that authorities have taken? Dr. Armenian, would you like to comment on that?
Unfortunately, as I look back over the last month or two as to what has been happening in the United States, it's been like a roller coaster situation, up and down, and overall, when I look at the bigger picture, I see that in such a situation, public health people and epidemiologists should be in the driving seat. Unfortunately, what we're seeing is in the United States is that in that committee or that leads through the White House, the leadership that represents the leadership of the epidemic, you don't have a single epidemiologist, including Dr. Fauci, who's an immunologist. He's doing a great job, but the specialists are not there from the CDC. The CDC director, I'm not sure what is his background. But what is happening in this country is that politics and economic concerns are driving the fight against this epidemic. Projections are being made that are very much off the charts, and these projections are not being made by epidemiologists but by statisticians, and there's a difference in knowing the disease epidemiology, in bringing in the disease epidemiology and concepts of epidemiology into the picture, rather than making some mathematical modeling and trying to express what will happen. Those models have failed in the past, and I'm not very much sure that those are based on the reality of epidemiology. Anyhow, Uh, I'm not very comfortable with what is going on in the US.
I see. So what just to continue on that idea, yes, I agree with the models. So the models are always as good as their underlying assumptions, and the assumptions remain assumptions, and it's really in this rapidly changing situation, it's really hard to make a prediction, especially that we are working with a moving target. But what I can say about the response of Armenian government, I think they have done a very good job. And then, of course, it's I look at it in the context of resources, both human and financial resources that they have. I think I can I would praise them with the how rapid and effective their response has been. But on the other side, I don't think that this is. I think I have highlighted this before, but this is not one person's fight. I think when we look at the situation, it's not that only authorities can solve the problem. This really requires a multidisciplinary engagement. I mean, starting from individual citizens, the society, the professionals, the businesses, and everything. So it's too soon to give a final kind of evaluation, definitely. But I think it would be a disservice if we just want to evaluate countries' measures just with the only actions that authorities have taken, because again, a lot depends on other players and individuals. With that, let's move with this second question, which talks about kind of about the effectiveness of masks and should we wear masks or not.
So you should answer that one because it's changing every hour on the hour.
Yeah, so I think it's a very good question. It's a difficult one. So what I can say, trying to rather than expressing my opinion, just share what the science on this is that currently, according to WHO recommendations, ordinary citizens who do not have the disease, they should not really put on the mask. So the masks are for healthcare workers. The masks are those who are infected, so they can prevent spreading the virus and the infection. And also those who are caregivers for COVID-19 patients. Nevertheless, there are a few pieces of information that's coming up, and that makes it a little bit difficult and more challenging. And that's the reason that there is actually currently an ongoing debate So there are kind of articles, not scientific articles, suggesting that the Asian countries which have advocated for use of masks widely by their citizens, they are doing better. But of course, I mean, you cannot really look at the masks alone, because they also have taken a lot of other measures. So to kind of try to only say that that's the reason that they are effective, it's because of use of the mask, would be a misconclusion. However, the arguments for using the mask, one of the arguments is that if COVID-19 confirmed cases are supposed to use masks, then having only those people use masks might lead to kind of stigma and discrimination against them. Whereas if the entire population wears masks, then that would be more equal situation. So you cannot identify the cases and perhaps have a discriminatory behavior towards them. So the other idea that is the piece of information which argues for use of masks is that we know that the disease and the cases are infectious and they can transmit the infection. before developing symptoms. And there are currently new studies showing that actually some of the cases can even be asymptomatic during the entire disease period. So the idea of advocating for masks is also for preventing those people, both at the asymptomatic stage or the entire stage of the disease, course of the disease, to prevent. But on the other side, we have the issue of incorrectly using masks, which can actually increase the risk of infection. You know, it's not putting the mask, it's not just it looks like a straightforward, but wearing the mask, sometimes it's uncomfortable, sometimes might lead that we end up touching our faces more than the usual. And of course, we all know that there is a significant shortage of masks, which might lead to people reuse their masks, and then, you know, that also increases risk of infection. So those are kind of the pieces of information and evidence that we have. But what we currently have in terms of a final recommendation, again, by WHO, is that you know, those who do not have the disease are not recommended to use the mask, but that might change. Okay, so let's move on with the next question. So the next question is about
the next one is again yours. Go ahead with your expertise on gloves.
So yeah, I think the gloves, it's something that it's about. It's somewhat popular in Armenia. I haven't seen that many in the US, but definitely gloves are not helpful. I mean, there is no evidence. If you wear the gloves, and then I mean, that's not really going to protect. Washing hands still remain the best intervention that one can do to protect themselves. So I think the short and comprehensive answer is gloves are not useful. They are not environmental friendly, and they definitely do not reduce the risk of infection. So the next question that we have is about a lot of different estimates about mortality. So what would your take on that be? So Dr.
Well, yeah, when I look at the data, at least in the last couple of days, from the last couple of days, mortality rates, as it's reported, vary anywhere between 12% to 0.5% of the reported cases. And this is a huge variability in terms of mortality rates as it's expressed from different countries. So what is important to consider is that we still do not have a very good handle on the subclinical portion of people who are these who have got the infection. Usually, as epidemiologists, we look at the iceberg of disease, which is the top of the iceberg, which is the what we see, which is the clinical side of the people who have the disease, is only a small portion of the mass of submerged part subclinical cases that we have in the population. We do not know how large is that submerged part of the iceberg of coronavirus. It may be 100-fold, 1,000-fold of what we see clinically, or it may be very limited. Of course, there is the data from the only, at least the one that is I'm familiar with, is the ship where everybody was tested. And we had a significant number of, what is it, by 25% or so, who were subclinical in that, on that cruise ship. But yes, the conditions on that cruise ship are not what we will find in a regular population-based estimates that we may try to do. And I do not have any figures on that submerged part, subclinical part of the disease. So based on the, so when you're looking at the, as epidemiologists, we're concerned, when we're making comparisons, we use rates, which has a numerator and a denominator. The numerator in this case are deaths from coronavirus, and the denominator are people who are infected or diseased. Now, what we're getting are the diseased part of the subclinical to a certain extent. Even I'm not sure that we're capturing all the disease in these numbers that we get. Italy, 12% mortality, that's too high. Probably there are some who are not captured in the denominator that we have, who have the disease, who are not captured, that is not captured by the governmental information system. And overall, European mortality rates are much higher. Is it because they report better the numerator, or is it because they do not have an appropriate denominator? So this variability is very much linked to our ability to measure the numerator, which is the number of deaths, and the denominator, which can be anywhere from clinical cases to a huge number of subclinical cases that we're not able to capture, except if we go ahead and test everyone, which is not the case.
Yeah, that's exactly the problem that we are seeing, and I want to also highlight that, you know, those are the way that you calculate the mortality. But another factor that is important is also the capacity of the healthcare system to respond. You know, the mortality from COVID-19 is also a function of the efficacy and effectiveness of the healthcare system. And that's one of the reasons that everybody is worried about having that peak being below the healthcare capacity, because if there are patients that they need ICU, they need intensive care treatment, ventilators, we know that out of 5 patients who get to ICU, 3 to 4 of them actually recover successfully. But if you don't have enough capacity to admit those 5 patients, then of course the rate of death and mortality would be much higher. So another question that we have in the chat is asking about, have we reached the peak of epidemiological curve in the US? And if not, what is your estimate regarding the time? So, you know, every state is in a different shape. I think that the kind of New York and New Jersey are kind of leading in terms of this burden of the disease, and they would reach the peak earlier. But none of these states, I think, have reached the peak. And remember, so there is the peak of getting infection, which comes first. And then there is the peak of hospitalization, which comes a few days later. And then there is the peak for mortality. So if you look at a daily basis, so it's not that, you know, there are different peaks. Probably we are getting close to the number of, to the peak for a number of cases, and the cases are slowing down in New York. But I'm not sure if we have reached to the peak of mortality, daily mortality, in the states of New York and New Jersey. And I think the other states are kind of behind, and you know, they'll still go through this cycle, hopefully not as bad as in New York and New Jersey, but that's what is will eventually happen with the epidemic curve in other states. So let's see the other questions that we have. So the other question that we have is, what can we do to protect ourselves and others? Oh, that's a very good question. I think that's a very important question. Definitely following the guidelines and recommendations, washing hands, social distancing, even though I don't like the term, and there is huge kind of discussion about that should be physical distancing, but because we can still be socially connected. I think we should be socially connected, especially if in this uncertain and difficult times. But physical distancing definitely is one of them. Washing hands, trying to avoid touching face, eyes, nose, and all those measures are definitely helpful. And basically following local health department and authorities. Is there anything you would like to add, Dr. Armenian?
Okay, I would like to remind that beyond what are recommended specifically for this the viral epidemic or pandemic, we have other preventive measures that should be emphasized more at this stage of the game than it was in normal times. Exercise, 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 building immunity, building health. Nothing beats exercise. So you have to develop the means of doing exercising, even if it's in your neighborhood, even if it's in on your treadmill or whatever the means you have. Exercise builds immunity. Exercise builds mental health. The second point that is one of my favorite subjects is dignity of the human being. It has an impact on health. And in this case, I'm very much concerned with with the older generation of people. It's not just to tell them isolate yourself and give them food and some money and then it's okay. It's not okay. You have to take care of them from a social perspective, the older generation of people who are most at risk, and supporting the sense of dignity of the older people is a very, very important aspect of preventive the public health under these circumstances, under these epidemics, because it's very unusual that they would not see people, they would be isolated from others. That's something that we need to be very conscious of. Exercise and dignity for the older generation.
Thank you. The next question that we have is about in the chat is about so first let's say this is the masks can be sterilized by putting them in the oven at 70 degrees Celsius for 10 minutes. Is that correct? So that's, I'm not sure about the time, but that has been the kind of practice that some of the ER physicians and other physicians in other departments that have been short of PPEs have to follow and reuse their masks. I know that there are chemicals like ozone and the other chemicals that theoretically can be used to, kind of sterilize the masks and PPEs, but we don't really have a robust research on that. And I was just recently following another webinar about this topic, and I know that there are current research studies going on to see how can the PPEs be sterilized to be reused, specifically in those countries that are in a limited function, in limited resources, but we don't really have a definite answer for that one.
I would like to add one thing that we do not, unfortunately, use very often, and that is sunshine. Exposure to sun for over an hour and a half, whether it's water or some of the foods, is being a traditional method of taking care of microbes, and that has been tested over and over the years. one of the things I do is put a bottle of water, transparent bottle, and an hour and a half, and then that takes care of all the bacteria and possibly some of these viruses which are relatively sensitive. So sunshine is something which is very much available in Armenia, in California, in much of this country. So let's use as much as possible, put stuff in sunshine for an hour and a half, and that will take care of it. In the olden days, we used to preserve grain from the putrefaction and other things in keeping them under sunshine, in sunshine. So there is an element there, but I'm not talking about masks, of course.
All right. So another question is about how is how the peak is calculated or estimated, and is it a proxy measure for hospital admissions, and how will peak be estimated for a country like Armenia? So all these estimates they kind of take into account different variables. One is of course the susceptible population. The second one is density of population, and then human behavior and whether there are measures taken or not, because the course of epidemic when it goes on unchecked is very different compared to when people start taking actions and measures. So usually the peak should theoretically come a few days after when the strict measures start, okay? But also that depends on how successful the healthcare system is in terms of testing, identifying cases, isolating them, contact tracing. So estimating a peak is really difficult without having all this information. So I think, for example, in Armenia, in terms of contact tracing and isolating, they have been pretty consistent over time. So if I had to think about the peak of the epidemic, I would say that the peak should come sometimes after enforcing this strict measures for infection control. That might be in about a week or 2 weeks or something like that, but not longer than that. But if it's the measures that they take is not effective, then even with some limited actions and measures, the infection can grow and grow, and the peak might be delayed, which of course would result in a higher peak. To go on, we have a question about how long is this pandemic going to last? Oh, that's a very good question. Do you want to comment on that, Dr. Armenian, or I should?
Oh, I'm not a prophet. Actually, we have a situation whereby, it is in my book about the Camino de Santiago, which we walk, and I mentioned this fellow Magar, who who was going to Spain for his pilgrimage, Camino de Santiago, and he was while he was in Belgium, he had the plague, and people were taking care of him, and he predicted that when he dies, the plague will stop, the epidemic will stop. So that's what happened. When he died, about actually a year later, the plague epidemic stopped. And then Magar became a saint in Belgium, and there were many churches and all built, for this Armenian guy. because he predicted the end of the epidemic. So why, if you want to become a saint, just predict the end of the epidemic?
Well, I wish I could, but it's very difficult to say. But I think I don't know. I mean, I always want to be optimistic, but it's really difficult to predict how long this pandemic is gonna last. But of course, we're gonna see the end of this pandemic. But I don't think that we're gonna eradicate the virus. And I hope I would be wrong on this one, but
I think something has to do with herd immunity. How much of the population will develop a certain level of immunity so that the virus stops spreading. Now, considering that much of Africa is still at the nascent with this epidemic, with this pandemic, still we have got, at least on a world level, we still have got a lot of expectation with regards to the timing on a world level. Individual countries may differ. We have got some good examples in the Far East, between Taiwan and Singapore. But even there, a second wave of the epidemic is not ruled out. Because as you get to a certain level of herd immunity, if you have not reached that level, a second wave or a third wave of the epidemic may hit the country. So we have to be very careful in making any predictions at this stage. Somebody is using the smallpox figures to say that if we have 2/3 of the population sort of immune, then we will stop the epidemic. That is specific for the smallpox, which was used for smallpox eradication, whereby when they vaccinated 60% of the population, they were able to eradicate the disease because of building. But herd immunity is based on in the smallpox case was based on a strategy which identified cases and then build a barrier around the case of vaccination. That is not happening here. This is a totally different situation, and we don't know where the herd immunity is going to get us to. So there's a lot of unknown at this point to be able to make any predictions.
Yeah, totally agree on that. So the next question that we have is about what do you think whether this infection is airborne or not. So I can take this one. Is that what we currently know that this is a droplet infection, not really airborne. So there are a few research studies that shows that some of the aerosols can stay in the air, but those studies, they actually created aerosols to see how long they can last in the environment. That transmission through aerosols, for example, can happen if physicians are trying to intubate the patient or some other medical interventions. Other than that, so the main route of transmission remains droplet, transmission through droplets, and also through the contaminated surfaces, subjects, and objects and surfaces, basically. So that remains the main route of transmission. So I don't think that there should be a concern about the airborne precautions, at least based on what we currently know.
Why do you think?
Yes.
Do you think fecal oral route of transmission is a possibility, considering that there is quite a lot of evidence that we can get fecal samples involved in this thing. Are there any studies that you have come across where there is possibility of such transmission?
So there have been studies that have shown that patients they can have the virus in their feces. Nevertheless, we don't really have an evidence that has led to a fecal-oral transmission. Again, theoretically, it's something that is possible, but practically, I don't think that's at least one of the mechanisms affecting a large portion of population. The problem with this virus is, this infection is that there is a lot that we don't know, and there is a lot that we will learn over the coming weeks and months and even years. But based on what we know, again, the main route of transmission remains the droplets and contaminated surfaces.
Okay.
So the next question is about, would warm weather help decrease the spread of the disease?
If I may, based on our experience from other viral infections, including childhood infections, which occur primarily in wintertime, particularly in developing countries, probably much of the reason of these viruses acting in the population in wintertime, including flu, influenza, and similar viruses, respiratory viruses, is possibly because of crowding during the winter times. In situations where we have crowding during the summer because of refugee camps and otherwise, the transmission, these viruses, these infections make their come up with small epidemics that we have documented. We have documented, for example, that in 1922, based on the records of the Armenian churches, that in Lebanon, in churches which are in refugee areas, we had measles and mumps epidemics in the summer, which usually do not happen. Similarly, during the Lebanese Civil War, where people were clustered in schools and other places, particularly refugees, there was resurgence of these infections, respiratory as well as childhood infections, happening during the summer. So hot weather, warm weather is probably not what is involved. It is crowding that will that will be contributing to the transmission of these viruses or infections. Actually, the socialized, whatever you call physical distancing, is something that will help preempt the transmission of the disease, not because it's summer or winter, but because it's avoiding crowding.
Yeah, so that's the good thing about. That's something that we are 100% sure that less crowding during summertime would definitely help. There are certain infections that they are more susceptible to warm weather. I'm not sure if COVID-19 is going to be one of them. So if we have that on top of the physical distancing that summertime would bring, of course, that would be great. But if not, we will definitely benefit just even from the physical distancing. So that definitely summertime is gonna bring some relief and a decrease in rate of infection.
Based on studies that we have done in hospital mortality some years ago, we have been able to demonstrate that temperature plays a role in higher case fatality rates in general in hospitals. So a summer type of weather condition or temperature conditions may lead to less mortality. But this is based on relatively old data from 20 or 30 years ago. Currently, most hospitals are where temperature is regulated with air conditioning and otherwise. This may not be the case.
Well, the next question that we have is that, so if the main route of transmission is droplets, does that mean that asymptomatic people are much less contagious? So what happens is that it might be that they are much less contagious because they are less likely to cough and sneeze in terms of spreading the droplets. However, the problem with the asymptomatic people is that when they are asymptomatic, they are less likely to be careful and, and take all the measures to prevent the spread. So yes, on one front, you have that asymptomatic people with less coughing and less sneezing definitely helps to decrease the risk of transmission. But on the other hand, you have people that are less likely to avoid someone who's asymptomatic just because that person might just look healthy and no sign of infection. So there is a give and take to that one, and that's just me thinking about this pieces and logically. I don't know. I haven't seen a research on that one. So the next question that we have, probably I would actually like to hear your opinion on this one, is Dr. Armenian, is that in the hindsight, was there anything that we could, it says, was this something that we could predict, and was there anything that we could do to prevent this outbreak?
I'm not sure that whether we could do something to prevent the outbreak, but in any such situation, what is important is to act and investigate as early as possible. Now, people today Chinese are reporting all the information technology methods that they have used and all that. I don't buy that. What they needed to do is investigate the first, cases that happened in Wuhan and focus on that. Unfortunately, much of our public health departments are not geared to look at unusual cases, cases that are out of the ordinary, whether in clinical symptomatology or with regards to the etiology that is possible to identify. So if we act early as possible, if we are able to identify the method of transmission, it is not about just finding the virus. We need to find out how that virus is getting to people, and in each of the constituencies, this may be different. Because social and cultural patterns differ between countries, across countries. The data from China on transmission may not be very applicable to Switzerland. So every constituency, every country, every outbreak needs to be identified and investigated. Years ago, we had 900 cases of cholera epidemic in Bahrain. One of the world's foremost cholera epidemiologists, who later became our dean at AUB, Jean Gangarosa, was in the region, and we consulted him and we asked him to look at the data from the epidemic. All we had to show him was age and sex distribution of cases. And then the head of public health in Bahrain said, Dr. Gangarosa, we stopped importing vegetables from Iraq. We have closed all restaurants and fast food operations. We have been vaccinating people. We have airport controls and all that. What else do you suggest us to do? And Jean Gangarosa, stopped for a second and he said, you need to do an investigation. But they said, well, it's fecal oral. But how does it get from fecal to oral is different in every different epidemic of cholera. It's in Naples, Italy, there was an outbreak a few years before. It was shellfish, which was the way this was transmitted. An epidemic in Jerusalem was transmitted, the cholera was transmitted through freshening of vegetables with dirty water, etc., etc. So this is where, the public health authorities have failed to use epidemiological investigation in every constituency. We have been just listening to WHO saying to us what to do, without investigating, without knowing our own situation. Maybe New York is different from California, or maybe California is different from China or whatever. So I'm raising this because we do not have appropriate epidemiological intelligence and appropriately trained epidemiologists who are doing this. Unfortunately, that's another failure of epidemiology of this part of the century.
Thank you. One thing that I want to say that there are scattered research studies, but I would say that you need more systematic, rigorous research. I mean, most of the studies that you see currently coming out of this pandemic is that most of them are as a side project to an ongoing crisis. Whereas I think if epidemiologists or researchers in general, they can kind of make research a priority and try to understand in the long run, that's going to really help to confront this outbreak and all this epidemic that is going on. But yes, that's definitely something that we unfortunately don't have. But I hope that over time, better research and would become available, and we'll have a better understanding, which can inform more effective interventions.
There is a saying in epidemiology, which is, we need an investigation because our intervention, when we go to do something, we do not have to do 20 things to prevent the cholera epidemic. We can just, take care of the shellfish industry there, or the vegetables in Jerusalem or whatever. We have to be as precise, as specific as the knife of the surgeon when he goes into the operating room to pick up an appendix or whatnot. He doesn't open the whole abdomen to find out what's wrong with the patient. Same thing with epidemiology and public health. We need to be as precise as the knife of the surgeon.
the next question that we have is about those people who are infected with COVID-19 and recovered. Are they gonna develop lifelong immunity? Well, so that actually that's a very good question, because that also is kind of tied to the concept of herd immunity. You know, when we talked about herd immunity and saying that a good portion of population, when it's gets the disease, and then are becoming they are becoming not at risk anymore. So that helps with preventing the spread of the disease. And of course, that assumes that those people who are infected and recovered, they develop lifelong, or at least a long time immunity. So for this specific disease, again, I'm afraid to say that we don't have the data, so we don't know how long the immunity would last. But if you look at the other flus, unfortunately, the immunity doesn't last for years. For a short period of time, yes, but that doesn't really long last. So that might be the case with COVID-19, which of course that would bring another challenge in terms of getting to a stage where we can benefit from herd immunity. But again, we don't have data on that. We don't know how the specific disease behaves.
There may be a situation similar with influenza. I don't know whether the virus itself, I'm not a virologist, but you know, we get a new epidemic of a new strain every year or every other year. And hopefully this will not be the case with this COVID-19.
Yeah, that's another concern, that if you know that if the virus changes over time, then of course it becomes more difficult, both in a sense of developing immunity and developing vaccination. And one of the comments that I see in the chat is that, you know, use of technology, information technology, AI, artificial intelligence in developing vaccines. I think that has been used actually for developing vaccine for this particular disease. I know some of the companies have successfully used that technology. We don't know whether the vaccines that they have developed would be effective or not. But that's those technologies that we have, and those all the computer science, it's being applied in pharmaceutical industry, and they are using it pretty widely. So I don't know again how effective the vaccine would be, but that's something that we'll learn in the coming months. So the next question is, he says, you are both doctors and public health specialists. How do you see the role of medicine and public health in tackling such epidemics? I'll leave this to you, Dr. Armenian.
Oh boy. Well, when we're looking at the whole issue of public health versus medicine, it's not one against the other, it's one complementing the other. In public health, we have been dealing with prevention, medicine dealing some prevention, but mostly focusing on treatment and rehabilitation. Public health needs also to redirect itself, not just on prevention, because prevention is dealing with disease. We need also to deal with building health, which is dealing with physiology, improvement of physiology. The difference, again, these are complementary, and when you know, there is this story about the guy, the physician actually, the medical person, walking by the river, sees somebody drowning, picks him up at artificial respiration, trying to resuscitate and all that. Then as he's working on that, there's a second body coming down to work on both. And then there is a epidemiologist coming down, walking down the banks of the river. And then there is this third body comes, and the physician says to the epidemiologist, why don't you take care of the drowning body? And the epidemiologist says, no, I'm going up to see who is throwing these people into the river and preventing people from being thrown into the river. And also teaching people how to fight back and not being, fall into being thrown into the river. So it's two necessary dimensions of healthcare, and they are both necessary. Hopefully, our role as epidemiologists and public health people will be to minimize what the medical people are going to do, to let them go bankrupt, out of work if we can. That's our aim eventually. So I don't think it's going to happen in my lifetime or even in yours, Vahe, but it's actually the main difference between the two of us.
I think I wanna add one more thing about this, is that public health, if you think about limited resources, so you can achieve actually way more, because public health interventions are way cheaper than medicine. So again, while both are important, in terms of return that you get on public health interventions is way higher than medical interventions. For example, thinking about treating patients with cancer, very important. We definitely have made a lot of advancements, and but if we can prevent that, for example, as simple as by not smoking, or for those who are smokers, quitting smoking, that will be way more effective than dealing with a disease which is quite severe and costly to treat. Another thing that I want to mention about, unfortunately, one problem with the public health interventions is that they often become victims of their own success. I mean, I'm just thinking about the case of measles vaccination. I mean, how successful was the measles vaccination across the globe? And then, at certain point, people said, measles, it doesn't really happen. Why are we vaccinating? Without realizing that the reason that we don't really have a problem with measles is not that measles is not a problem, but it's because the vaccines are working effectively, and vaccines are preventing a lot of disease and deaths. But we often don't realize that. And what happened is that once the vaccination coverage for measles dropped, and we saw quite a lot of outbreaks in Europe, in the United States. So I think that's kind of the make a balance between both medicine and public health, but also sometimes we are not very efficient in seeing the impact of long-term impact of public health interventions. All right. So let's see questions. Another question that we have is about undoubtedly this pandemic has caused significant health and economic loss. Is there anything positive that this pandemic can bring? Oh, that's a very good question.
Okay. Well, definitely there is always a silver lining in every one of these adverse situations. And possibly I see so many families spending more time together. The social interactions are improving at certain levels. And like every major adverse situation in a disease, there will be definitely improvements in healthcare organization as well as technology that is used in both prevention and treatment, and that will have wider ramifications than just the COVID virus or the corona outbreak. So the way it happened, for example, in HIV research, that totally transformed the infectious disease epidemiology and infectious disease the management and our understanding of chronic infectious diseases. One thing that I would like to highlight is something we have learned during 12 years of working in Beirut in the civil war in Lebanon, is that if it's important to think of a frame of mind that is positive for health professionals and with everybody, all professionals and everybody. I learned from that experience that adversity is an opportunity for positive achievement. Can you turn around this particular adverse situation when many of us are stuck at home and all that into building something different, something better? This morning at 6 a.m., like every Wednesday at 6 a.m., we have the Turpanjian Rural Development conference call with people, with our representatives from the five regions of Armenia, Artsakh, and Jabakh. And that's the plea that we made with our regional representatives, that all the businesses that are not operating under the circumstances, we've got over 500 businesses that were developed in these 5 regions, that all these businesses that they think they are failures under these circumstances, can we make it such that we turn them around and then make them think and develop into new ways of doing things? Even something like a bed and breakfast in Armenia, in Vahe Khachadourian, can use this time, although tourism is down to 0 in Armenia at this point. But can the bed and breakfast that we have today be tomorrow after this epidemic be better than what it was? What are things that they can do to improve whether it's service or facilities or whatever? So adversity is an opportunity. Let's think about that in positive terms. And that's how Armenians have dealt with these situations, and that's how they should do.
So I think that's definitely there are a lot of opportunities, and the list of which is that hopefully the healthcare systems and all these countries that they go through this, they become more responsive and stronger and more prepared for the next epidemics. If you look at what happened in China, one of the reasons that they were successful in containing the epidemic, given given that they started from where that they were the first country that they're affected by the disease, so they didn't even know about it at the beginning. But one of the reasons that they were successful about this is that because they had gone through several similar epidemics, including SARS in early 2000s. So that, of course, has prepared and strengthened their system for a better and effective response to this, similar outbreaks. And I hope that at least one thing that the healthcare systems get out of this is to be prepared, to be proactive, and to be responsive and prepared for such, I would call them black swan. I'm sure you would agree, Dr. Armenian.
Yep.
So yeah, we have some, okay, let's take one more question. It says, why in some countries, for example, in Italy, the rate of critical care is very low, but the death rates are still very high? Honestly, I haven't really looked at the critical care rates in Italy and the death rates, but one of the reasons for that might be...
It's 12,000 deaths yesterday out of 100,000 or so cases.
So that means that what they have is about 12% mortality. So that 12% mortality can be a function of various things. One is the underlying population. We know that the age distribution in Italy, it's definitely the portion of population above 65 is definitely higher compared to other countries. So that might be one reason. The other reason which might be the case is that they are probably diagnosing more severe cases. So they are missing the mild cases and asymptomatic cases. And the third reason for that, of course, would be that overwhelmed healthcare system. Again, I talked about this, that, yes, even those patients that they end up in ICU, most of them successfully recover. But if you have a situation that those patients who need ICU care and they are not able to get that, then of course the odds are not very good. So again, I don't know what's exactly happening in a sense of how overwhelmed the healthcare system in Italy is, but that might be also one of the reasons. Because I was just following the situation in New York, and what they're saying is that they are saying that the healthcare system would be definitely overwhelmed. They are in a shortage of ventilators, PPEs, everything basically. So of course, in that situation, nobody thinks that the mortality of around 1% would hold, because if the healthcare system cannot respond, then you will have a different situation. Anything you would like to add, Dr. Armenian?
No, I'm okay.
Okay, so I guess we can conclude. So anything else you would like to mention before we conclude, Dr. Armenian?
I like to see things in a systematic, organized way. And we need to sit down and set up a system that addresses all three levels of intervention, which is prevention and building health. That's number one. Treatment, rehabilitation, because we still don't know what rehab problems and long-term problems we will have with the survivors of this epidemic. And that's another question. There was a time, for example, that people developed a hypothesis that there was a Parkinson's sort of epidemic in about 20 or 30 years after the influenza pandemic of the 1918, 1920. That didn't pan out to be true, but that's the sort of thing one would expect following this sort of epidemic or pandemic to happen. And so the long-term follow-up of things is very much very important in this sort of epidemic for survivors of this epidemic. Also, the other dimension of things is what do you do on a personal level, at the level of families, and what do you do at the level of populations? There are interventions and preventions and preventive interventions, curative interventions, as well as long-term interventions in every one of these units of persons, units of families, and units of population. And this sort of a matrix type of an approach would map out a set of policies and the interventions that would hopefully be adopted and budgeted and be part of a long-term plan for this epidemic.
Yeah, thank you. That actually, when you said about building health, that reminded me. So I'll share this. I remember when I first moved to the US for my PhD. I remember I came to your house, and then for a discussion about, okay, what courses should I take at UCLA, and what classes, how should I plan, and all this discussion. And then you said, the most important thing is to exercise, and then you gave me a set of hiking gears, which until today I haven't used it. So yeah, definitely I agree. I think building health is definitely important, and then especially now that seeing being fit can protect us from this infection. That highlights, even further highlights the importance of being healthy and doing exercise. So one thing that I want to mention is, probably before we conclude, is that again, this is everyone's fight. I mean, we should definitely do our part. We should take care of ourselves and others. And if you're young, that doesn't mean that you should not really follow the guidelines and do your part, because eventually this is going to affect the entire society, and it's going to be either directly or indirectly, it's going to affect everyone. I know it's a very difficult time, both socially and economically, but I'm sure that we're going to get through this. All right. Thank you, everyone, for joining us today, and for your pretty thoughtful questions. Thank you very much, Dr. Armenian. It was a pleasure to have this session with you. I hope you stay safe and healthy, and everyone stay safe and healthy. And
yeah, and
yes.
Thank you, Vahe, and keep the flag of epidemiology high in Armenia and elsewhere.
Absolutely, sure. I'll do my best.
Okay.
All right.